have to go on this page and change the amount of class 2 here. Make it a little more than 3 because that option will be available to you only when the amount of class 2 is between 3 to 5. Okay? That's a little bit of modification that you have to do on your software so you can get the simulation. If I'm doing distalization plan, 2.7 is upper 7 extraction plan. If I'm doing those plans, and these are difficult treatment plans to sell to the patient, how easy is it going to be for you to tell the patient how to remove one of your molars? It's not going to accept that so well. So if you show them a simulation which shows how it's going to be after you finish, maybe you can use this as a marketing tool to sell your plan. But if you want to get the 2.7 simulation, you have to make sure the amount of class 2 is between 3 to 5. Okay? Load in size and inclination and tissue thickness. This is a very, very important criteria to determine if you can treat the patient non-extraction or not. And that's what I've written on the second side of the screen. It shows you how much your incisors will advance and do you have the tissue and the bone available for the incisors to advance. So when you do your Ceph tracing in a couple of days when I teach you, you will be drawing the symphysis anatomy very, very clearly. And that shows you how much bone is available for this tooth to come forward. If you don't have bone, tooth can still come forward by a process called bone remodeling. Bone can just keep getting remodeled and teeth can still be maintained a little bit outside the bone. But that's called skeletal resistance. Tooth is not allowed by the bone to move forward, but again with low forces, the bone can still remodel and come out, but to an extent. You can't expect it to come all the way outside. Okay? So on the MOS, it shows you the position of the bone, and you compare the position of the bone with the position of teeth. If you feel that the teeth are within the bone, then it's considered to be an achievable situation. If it's on the bone, it's still possible. If it's outside the bone, then you know it's not possible. Okay? Also talking about your tissue thickness. So when you decide the tissue thickness, you measure the distance from the free gingival margin to the mucogingival junction. Okay? So if you have a width of attached gingiva, which is less than 2 millimeters, it's considered to be thin. Okay? If you have more than 2 to 4 millimeters, it's moderate. More than 4 millimeters, it's thick. Thicker the gingiva, the less resistance it is to recession. When you look at the gingiva, you have to look at gingiva everywhere. Anterior is for advancement, and even the canine. If you're expanding, you should look at the premolars and the molars. So look at, this is called, like in implantology, we call this as biotype. We call this thin biotype and thick biotype. It's the same thing. If you have a thick biotype, then your grafting will go better. If you have a thin biotype, then it's not so good for implants, right? So we see that in many specialties of dentistry. You also have to see the starting incisor inclination, like the example I gave you there. If your incisors are retroclined in the beginning and you advance them forward, it becomes average, it's still okay. But if it's already proclined at start, you can't afford to procline them further. So you need to look at other methods of doing it. So the line is excessive proclination is equal to recession. Okay, so you have to make sure. So what happens if you already have recession before you start your ortho? Some of your adult patients, they come to you, they already have gingival recession. Can you do ortho for them? You must refer them to a periodontist and fix the perio first. Fix the perio before you can fix your ortho. Okay? So do you have periodontists who come to your practice here, or you send them out? Send them out? Oh really? For us, we actually bring them in. So we call the periodontists. We have some certain fixed days in the week, like Tuesdays, Thursdays, 3 p.m. The periodontist, she comes to my practice, so we keep them at that time. But it's not very common for us to do a free gingival graft, although it's academically possible, but it's not a very popular procedure because just the lack of awareness and not too many people accept another surgical site to place it there. So, but if you have a patient who will accept it, the procedure is very successful in the hands of a good periodontist. So you can really consider that. So then only you can do your ortho. That increases the biotime.
Does it fix mobility or not?
Mobility comes out of bone. So if you want to fix bone, then you need to do bone grafting. If your patient has bone loss with recession, then you need to see if it's vertical bone loss or angular bone loss or horizontal bone loss. If you have horizontal bone loss, it cannot be fixed. If it's angular bone loss where you have 2-wall defect, 3-wall defect, 1-wall defect, which can take up bone grafting, then it can be predictably successful. Okay? Most of the mobility, in my opinion, when you have mobility of teeth, is because of what? Do you think it's because of hygiene? I've started believing this a little bit more, that this mobility is more from trauma from occlusion and then the hygiene. Okay? So I've had patients who had terrible hygiene but no mobility versus someone who maintains them well, still has mobile teeth. Especially these guys who have anterior crossbite. If you look at their teeth, they'll always be slightly mobile because the trauma from occlusion is creating. And what's the best way to fix that? Is it grafting? Is it bone graft? Or is it ortho? Ortho, right? Ortho can fix trauma from occlusion much, much better than anything else. I've seen mobility reduce because the trauma is removed. You two guys want to sit there? I wanted to see you. Can you see me? Can you hear me or you can't see me? So those two tables are empty. Now, if I'm standing here, I feel like I'm blocking the screen. So we are in a very small real estate here. I don't know where to go. So I'm sitting here. I'm sitting here, I can't see you. So we have two nice chairs and a beautiful table there in case after lunch, maybe whenever you're comfortable. If you don't want to see me, you can still sit there. But I'd like to see you. Okay. Other aids to correct class 2. Control the habits, we spoke about habits. Close the vertical. There's something called occlusal plane, okay? And the amount of class 2 and class 3 has got something to do with the occlusal plane. Every time your occlusal plane rotates clockwise, it worsens the class 2. If your occlusal plane rotates counterclockwise, it improves the class 2. Having said that, what are the methods by which you can expect the occlusal plane to rotate clockwise? When you use class 2 elastics. When you use class 2 elastics, the lower molar feels two forces. One is a mesial force, that's to correct the class 2. Second is a vertical force to extrude the molar. If the lower molar extrudes, what happens to the occlusal plane? Bite will open, right? As the bite opens, the occlusal plane will rotate clockwise. And every time the occlusal plane rotates clockwise, it worsens the class 2. That's why when you use too much of class 2 elastics, you're correcting the class 2 and you're creating the class 2. Correcting the class 2, you're creating the class 2. It's like you writing PTO on both sides of the paper. You keep turning the paper, right? PTO. Please turn over, please turn over. That's what happens. You keep correcting class 2 and you keep creating that. What are the methods you know of rotating the occlusal plane counterclockwise? When you do skeletal anchorage for upper intrusion, when you intrude the upper incisors, the entire plane goes up and the mandible will overclose. As the mandible overcloses, occlusal plane will rotate counterclockwise. So the amount of class 2 will reduce. Okay? The occlusal plane has got a strong bearing on, we have a lot of class 2. For class 3, it's the reverse. As the occlusal plane rotates clockwise, what happens to the class 3? It improves. And the rotation happens clockwise. If the class 2 worsens, then the class 3 improves, right? That's the reason why whenever you use a reverse pull headgear, the external appliance that is used to correct the class 3, the line of force of a reverse pull headgear is always forwards and downwards, because they want to open the occlusal plane clockwise. As the occlusal plane rotates clockwise, the class 3 will reduce. That's the reason why we give the line of force. That's very common for you to have class 2 on one side and class 1 on the other side because of a functional shift. Okay? Say I have class 1 on right side, 4 millimeters class 2 on the left side. The lower midline is shifted towards my right. Okay? That means I may be having a functional shift. What are the clinical signs you should look for when you suspect a functional shift? Number 1, I spoke to you about horizontal overjet this morning, right? What is horizontal overjet? Space between the canines. If you have horizontal overjet present only on one side and no horizontal overjet on the other side, that's a sign of a functional shift. Okay? Horizontal overjet present on one side and the lower midline is shifted on the side opposite to the horizontal overjet. It's called a functional shift. Number 1. Second, when the patient is in occlusion, the upper and lower midlines do not meet. But when you ask the patient to open the mouth, with the teeth separated by 2 to 3 millimeters, you will see that midlines will meet. That's another feature. Clinically, you have to see if the patient is having functional shift. Third, if you see the frontal ceph of this patient, you will see the menton is not on the mid-sagittal plane. The menton will be away from mid-sagittal plane. That's another sign of functional shift. Number 4, the first and the second molars of the lower arch will not be aligned on that patient. These are all features you should look for when you have suspecting a functional shift. Okay?
So, when you mention first and second molar not aligned,
Yeah.
it's aligned to when?
Oh, okay. Let me just show you a picture. So whenever you're not sure, just ask me so I can add some more information to that. Look at that picture. The side on which the mandible is shifted will not have 6 and 7th line. So 6 is buccal, 7 is lingual. It shows that the functional shift is towards the patient's right. Does that make sense? What do you see in this picture? Does this patient have functional shift? So you have horizontal overjet on the left side and the midline is shifted on the side opposite to the right. That means this patient has functional shift towards her right side. How do you fix a functional shift? You have to use anterior cross elastics. Whenever I say anterior cross elastics, it's very frequently confused from which tooth to which tooth? So from where to where the anterior cross elastics go in this case? Tell me the tooth number. 4-3 to 2-3. 4-3 to 2-3. So that the elastic can push the mandible towards the left side. Okay? And this is time when you want to see the patient in 2 weeks. Because the functional shift correction with the anterior cross elastics happens very quickly. Okay? See them every 2 weeks. Moment the midlines are centered, functional shift is corrected. Now it becomes very easy for you to fix the remaining case. Okay. Can you see this picture versus that picture? It's the same patient. When I take the picture of the patient and ask them to open the mouth, suddenly I see the midlines are getting centered. Compare this to the previous one, it was shifted to one side and opened by. Because the prematurity is removed, it will center again. Okay? And on the side of the shift, you will see the posterior teeth are not aligned. All of this suggests you have a functional shift. Yeah.
When we use the anterior cross elastics, we use it when the arch bar is 19/25.
Yes. You could also do it 18/25. As you're aligning, you can also use anterior cross elastics on 18/25. Because you're going to use it only for a short time. If you use long elastics on 18/25 for a long time, it can create a deleterious effect because the wire is flexible. But you're using it only for 2 weeks until the midline is centered. On your setup, if you send this case to a aligner company, so it's all about aligners now. Sometimes you may feel a frequent disconnection in this group because I see that not too many of you are doing aligners. So whenever I say aligners, I'm like, oh, why are you talking about it? We're not even going to do it. But I can tell you, I was not doing a lot of aligners until a few years ago. But every patient who walks into my practice today wants only aligners. So if you're not started doing it yet, it's about time that you learn it. If you learn it, then you'll start doing it. Okay? So when the setup comes for you to you, you'll see in the setup that everything is getting straight. The setup cannot correct the functional shift. It can only straighten teeth. In the end of the shift of the setup, you will see a jump. Jump is, you will see that the midline suddenly moves on one side. That's what they add from the aligners setup, that showing you that the midlines are getting corrected now because of the function. Setup typically shows you teeth getting straightened, and the end, the word that they use is called a jump. Jump is in one stage, you will see the entire mandible will just move. For example, if you use class 2 elastics, in the setup, you will see all your teeth are getting straighter. In the end, you will see a jump, where it's telling you that this is what you should expect to finish because teeth are moving forward. Okay? That's how your jump works. You see this video? Can you see the jump? That's how the jump works. In one stage, you will see the whole thing gets centered. And these anterior cross elastics can also be used on aligners. If you want to use anterior cross elastics on aligners, you have to ask the lab to give you button cutouts in the aligners. You can see that this aligner has a cutout here, cutout here. Wherever you have a cutout, you will go bond a composite button, tooth-colored button. And in your kit, you have that mold. Did you guys do the hands-on exercise for the mold in seminar 2? Where you had to just fill the composite and then put it on the tooth and you cure it. Show me your seminar 2 work. The inspection. In your kit, you have a tool. You have a kit. Did you see that kit? It's very nice mold, and you just have to fill composite. Otherwise, what's your second option you have for this? You have to put a metal button. Do you think a patient is going to accept a metal button there? No way, man. I paid you 1.5 times more because I don't want any of these stupid metals in my mouth. And today you put a metal button. I had a girl and we ran out of time because we could not bond a composite that day. I asked her, so she just put a metal button and asked her on relaxing. I thought she wouldn't notice. She came back the next morning. Before I reached my office, she was sitting in the waiting area. Take it out. Did you find it? Sylvia, I know you bunked the last class. You didn't use it. This is how we catch you. So you have a small handle and you have a lot of attachments. You put the attachment in it and you have different types of attachment. One is for your button, one is for your cleat, one is for your tongue trainers. Okay, depending upon the shape you have inside. You fill composite, etch it, bonding agent, cure it, put it there, cure it, and remove the attachment. You will have a beautiful shape of it. Just wondering how come you guys are not aware of it. You should know it. You didn't do it? You didn't have time to do it? Okay, you ran out of time. Okay, that's why. Can I show you? Because you will do it and you will need it.